Broadcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And this is our first episode of 2021. So wish you all a very happy, prosperous, and joyful new year. Maddie, happy new year to you as well. And how was your new year celebrations and what are your new year resolutions?
My new year celebrations weren't too exciting because I had work, which finished late, and then watched the fireworks on TV. Nothing much to report. But I think everyone seemed to be quite quiet this year. And then, I don't know, I'm trying to study for fellowship. So hopefully pass that this year and then can think of life outside a bit more. How about you?
So my celebration is pretty much similar to you. So I was working till 1st of January. So no much celebrations there. But resolutions wise, I think this time I do have some better resolutions than you because I don't need to do any exams. But I got selected in Army Reserves and looking forward to that path. Also trying to work on my physical fitness and trying to get now 6 packs. That's my...
Good luck.
Thanks. Okay, let's get back to our podcast. So this is our second episode of Respiratory Physiology. And this is probably the most important or the core part of the respiratory physiology. So Maddie, let's start with some of the key concepts from the respiratory system. So can you please describe how is ventilation controlled?
So the control of ventilation can be quite complex, but we can think of it in terms of sensors, a central integrator and effector model. So the sensors consist of central chemoreceptors, peripheral chemoreceptors, mechanical receptors within the lung, and some other less important receptors. So the first sensors are the central chemoreceptors. These are located on the ventrolateral surface of the medulla and are surrounded by the extracellular fluid of the brain. So the composition of this extracellular fluid is mainly governed by the CSF. The central chemoreceptors respond to changes in the concentration of hydrogen ions. So an increase in hydrogen concentration results in increased ventilation. However, the blood-brain barrier is relatively impermeable to hydrogen and bicarbonate ions, but CO2 can diffuse across this blood-brain barrier easily. Therefore, when the CO2 concentration of blood rises, it diffuses into the CSF and decreases the pH, resulting in an increased ventilatory drive. The next sensors are the peripheral chemoreceptors. So these are located in the carotid bodies at the bifurcations of the common carotid arteries and the aortic bodies near the aortic arch. The carotid bodies have a very high rate of perfusion and consequently a very small arterial venous PO2 difference. This allows them to rapidly respond to changes in arterial blood gas tensions. The carotid bodies transmit signals to the medullary respiratory center via the glossopharyngeal nerve, while the aortic bodies transmit it via the vagus nerve. The peripheral chemoreceptors are mainly stimulated by a decrease in arterial partial pressure of oxygen. The firing rate is non-linear, and there is very little response until the PO2 is less than 100 millimeters of mercury, after which the response increases dramatically. The carotid bodies are stimulated by a decreased partial pressure of oxygen, not by reduced oxygen content. Therefore, there is minimal stimulation in situations such as anemia. An increase in PaCO2 also stimulate the peripheral chemoreceptors, but this is to a much lesser extent than the central chemoreceptors. The carotid bodies, but not the aortic bodies, are also stimulated by some other factors. These are a decrease in arterial pH, an increase in temperature, any sort of hypoperfusion, such as in profound shock states, and metabolic changes such as hypoglycemia, drugs such as nicotine, acetylcholine, or cyanide. The next receptors are mechanical receptors. These include pulmonary stretch receptors, which are within the smooth muscles of the airways and are stimulated by increased distension of the lung. Increased stretch of these receptors cause them to discharge, and the impulses travel via the vagus nerve and result in a slowing of respiratory frequency. This is known as the Herring-Brewer inflation reflex. The next receptors are noxious receptors, which are present between airway epithelial cells and are stimulated by dust, cold air, and noxious gases. They also travel via the vagus nerve and result in bronchoconstriction and tachypnea. J receptors are endings of non-myelinated C fibers, which are within alveolar walls and respond to chemicals within the pulmonary circulation, causing rapid, shallow breathing. And there are bronchial C fibers, which are within the bronchial circulation and respond to chemicals there, causing bronchoconstriction and tachypnea. Other side receptors include airway receptors, which respond to irritants by coughing and sneezing, joint and muscle receptors, which are thought to be important in exercise-induced increased ventilatory drive, arterial baroreceptors, which cause reflex hypoventilation when hypertension occurs, and pain and temperature receptors, which cause hyperventilation. The next important part of this model is the central integrator. So the normal automatic breathing pattern is generated within the respiratory center in the medulla. There are two main groups of neurons, the dorsal respiratory group and the ventral respiratory group. The dorsal respiratory group lie close to the nucleus tractus solitarius and is predominantly composed of inspiratory neurons, with upper motor neurons passing to the contralateral inspiratory horn cells. The dorsal group is mainly concerned with the timing of the respiratory cycle. The ventral respiratory group contains a number of neurons. There's the caudal ventral group, which contains the nucleus retroambigularis, which is mainly expiratory and has upper motor neuron axons passing to the contralateral expiratory muscles. They also contain the nucleus paraambigularis, which has an inspiratory function and has upper motor neuron axons passing to the contralateral inspiratory muscles and controls the force of contraction. The ventral respiratory group also contains a rostral ventral respiratory group, composed mainly of the nucleus ambiguus, which is involved in airway dilatation of the larynx, pharynx, and tongue. There's also the pre-Botzinger complex, which is thought to be the anatomical location of the central pattern generator of the respiratory system, and the Botzinger complex, which has expiratory functions. Other important areas are the pons, which contain a pontine respiratory group, which is thought to influence the medullary respiratory neurons and help control the rhythm of respiration, and the cerebral cortex, which is important for behavioral and volitional control of respiration, such as during speaking and singing. Finally, there are the effectors, which include the muscles of respiration, such as the diaphragm, intercostal muscles, abdominal muscles, and accessory muscles.
Thanks, Maddie. That's a very comprehensive answer. And let's move from the control of respiration to more inside the lungs now. One of the key component of alveolar lining is surfactant. So can you please describe what is surfactant, what's the structure, and what are the main functions of surfactant?
Surfactant is a lipoprotein complex produced by type 2 alveolar cells in the lung, which is responsible for lowering the surface tension of the alveoli air-liquid interface. It is comprised mainly of phospholipids, of which the majority is dipalmitol phosphatidylcholine. The remainder of surfactant is composed of proteins and a small amount of neutral lipids. The phospholipids form a monolayer, which have a hydrophobic ends which project into the alveoli, and hydrophilic ends which lie within the alveolar lining fluid. There are 4 types of associated surfactant proteins: surfactant protein A, B, C, and D. A and D are hydrophilic, while B and C are hydrophobic. A and D are known as collectins, which are a family of innate immune proteins and activate alveolar neutrophils and macrophages. Surfactant protein B enhances the surface tension reducing properties of surfactant, and surfactant protein C is thought to stabilize the phospholipid layer. Surface tension is a cohesive force exerted upon the surface molecules of a liquid by the bulk liquid beneath, which makes the liquid assume the shape that has the least surface area possible. The law of Laplace states that transmural pressure is equal to 2 times the surface tension divided by the radius. Therefore, increasing surface tension or decreasing radius will increase the transmural pressure and increase the likelihood of alveolar collapse. Surfactant reduces the surface tension at the alveoli air interface by reducing the cohesion of the liquid molecules. This reduces work of breathing and prevents alveolar collapse. Furthermore, as alveoli decrease in size, the surfactant molecules are brought closer together and exert more of an effect on surface tension. Surfactant is also thought to have an important role in the innate immune response and modulation of the immune response via these surfactant proteins.
Thanks, Maddie. So one of the key applied physiology with regards to surfactant is most of the patients with ARDS, they usually lose this activity, and that's why we need to apply positive end expiratory pressure or PEEP, keep alveoli open, because these patients, they do not have the surfactant lining, and that's why they tend to develop more collapse. Now, that brings us to our next question, which is probably the most important concept in respiratory physiology, that is functional residual capacity. So, Maddie, can you please describe what is FRC and what are the key factors affecting FRC?
So functional residual capacity is the volume of gas remaining in the lung following a normal passive expiration. It is composed of the residual volume plus the expiratory reserve volume, and is normally approximately 30 to 35 mils per kilo. The functional residual capacity also represents the point where the elastic recoil of the lung tissue is in equilibrium with the chest wall outward expansion. Now, the FRC is important because it is the point where the pulmonary vascular resistance is at its lowest. It is also representative of compliance. A decrease in compliance will decrease FRC. It also represents the point where work of breathing required to inflate the lung is at its lowest, that is optimal compliance. It provides an oxygen reserve, therefore gas exchange continue during the whole respiratory cycle, and it prevents collapse of small airways, thus minimizing atelectasis. FRC is affected by multiple factors. So it's affected by changes to inward recoil of lung or the lung compliance. It increases in conditions such as emphysema due to alveolar destruction. It's decreased in conditions such as ARDS due to decreased lung compliance. It is also affected by changes to outward expansion of the lung or chest wall compliance. So decreased FRC will result from conditions such as kyphoscoliosis or severe burns due to decreased chest wall compliance. This is also the case for pregnancy, obesity, or increased abdominal pressure, which increases pressure on the diaphragm, decreases chest wall compliance, and therefore reduces FRC. General anesthetics will reduce the diaphragm tone and also decrease the FRC. And position, FRC is greatest when upright and decreases by about 20% when supine. The next factor that affects FRC is lung size. So people who are taller have generally larger lung volumes than FRC, and men generally have larger FRCs compared to women. FRC also slightly increases with age. A decreased FRC results in multiple effects. It causes decreased lung compliance and increased airway resistance, thus resulting in increased work of breathing. It decreases the oxygen reserve, increases atelectasis, which may result in increased shunt, and increases the pulmonary vascular resistance, which may cause an increase in right ventricular afterload.
Thanks, Maddie. So as I said, FRC is probably one of the most important concept in respiratory physiology. And the key applied concept to FRC in medicine or in ICU is the importance of pre-oxygenation before we decide to intubate any patient, because that will help to maintain or improve FRC and maintain that oxygen reserve. Now, the key methods that are used to measure FRC are body plethysmography, inert gas dilution using helium, or it can be also measured using the nitrogen washout techniques. So in exam, you might be asked the question around FRC and also what are the different methods used to measure FRC. So next concept, which is closer to FRC, is closing capacity. So can you please define closing capacity and outline the factors that alter it? And also, if you can tell us what is its clinical significance and what are the kind of methods used to measure closing capacity?
The closing capacity is the maximal lung volume at which airway closure can be detected in the dependent parts of the lung. It is composed of the residual volume plus the closing volume. Small airway closure occurs when the elastic recoil of the lung overcomes the negative intrapleural pressure that keeps the airways open. This is more likely to occur in dependent regions of the lung where the airways are smaller. Normally, closing capacity is less than FRC, but it does increase with age. At approximately 44 years of age, it equals FRC in the supine position, and at about the age of 66, it equals FRC in the upright position. Factors which increase closing capacity include age. So as we just described, closing capacity increases with age, but closing capacity is also increased in the neonate population due to their decreased lung compliance, their very compliant chest wall, and their decreased ability to maintain negative intrathoracic pressures. Obstructive airway diseases such as COPD also increase closing capacity. Closing capacity is also increased with increased expiratory airflow and effort, and increased pulmonary blood volume, such as left ventricular failure, due to the increased pressure on the dependent lung. Decreased pulmonary surfactant and pulmonary parenchymal disease also increases closing capacity, as does any increase in intra-abdominal pressure. An increase in closing capacity will cause increased atelectasis, which may result in shunt and hypoxia. It also causes cyclic atelectasis, which results in injury to alveoli and bronchioles. Increased closing capacity can also result in gas trapping, reduced lung compliance, and further injury to alveoli. Closing capacity can be measured by inspiration of a tracer gas such as xenon at the beginning of inspiration from residual volume. This is when airways are closed in the dependent parts of the lung, so the tracer gas will preferentially be distributed to the upper parts of the lung. After a maximal inspiration to total lung capacity, the patient slowly exhales while the concentration of the tracer gas is measured at the mouth. Initially, dead space gas will come out, and the concentration of tracer gas will not rise. Following this, the tracer gas concentration will increase and then plateau. When closing capacity is reached, the dependent airways will close, and the tracer concentration measured at the mouth will once again rise, as only the upper alveoli, which contain more of the tracer gas, will still be open. This method technically measures closing volume. Residual volume cannot be measured directly, but can then be calculated by measuring the FRC with body plasmography, helium dilution, or nitrogen washout. Expiratory reserve volume can then be measured with spirometry. As FRC equals expiratory reserve volume plus residual volume, by subtracting the expiratory reserve volume from FRC, we can then obtain a value for the residual volume. This can then be added to the closing volume previously measured by xenon technique, and then calculate the closing capacity.
Thanks, Maddie. So again, very important concept that you need to understand, because when FRC, as you mentioned, approaches the closing capacity, that's where alveoli start collapsing. And one of the key factors is it depends on the age. And that's why elderly people are probably more prone to develop atelectasis faster than the younger patients. Another key concept to think about in respiratory physiology is mixed venous oxygen saturation or partial pressure. So can you please define mixed venous PO2 and briefly describe the factors that influence the oxygen content in mixed venous blood?
So mixed venous PO2 is the partial pressure of oxygen within the pulmonary artery. This contains blood mixed in the right ventricle and is representative of the venous blood and therefore the oxygen extraction from the rest of the body. The normal value is 35 to 40 millimeters of mercury. Oxygen content of the blood is dependent on the amount of hemoglobin, the saturation of hemoglobin, and the partial pressure of oxygen, where the oxygen content equals generally 1.34 times hemoglobin multiplied by the saturation of hemoglobin plus 0.003 times the partial pressure of oxygen. The partial pressure of oxygen of mixed venous blood helps determine the saturation of hemoglobin via the oxygen-hemoglobin dissociation curve. This curve is slightly right-shifted for mixed venous blood compared to arterial blood due to the Bohr effect. Factors influencing the mixed venous oxygen content include factors which impact on oxygen delivery and oxygen consumption. So oxygen delivery factors include cardiac output, hemoglobin concentration, hemoglobin saturation, and the partial pressure of oxygen within the artery. Factors that decrease oxygen delivery, such as low cardiac output states, or increase oxygen consumption, such as fever, will decrease the mixed venous oxygen content. Factors which increase oxygen delivery, such as high PaO2 or decreased oxygen consumption, such as impaired tissue uptake in cyanide toxicity, will increase mixed venous oxygen content. I think it's important to also realize that there's a difference between the partial pressure of mixed venous oxygen, the mixed venous oxygen saturations, and the oxygen content in mixed venous blood. These have all been asked before, and people have previously gotten confused between all these concepts.
That's correct. And again, it's very important to understand the difference between these three terminology. And mixed venous oxygen saturation, usually we need to measure using the PA catheters, because sometimes people again get confused between using CVCs to measure oxygen saturation, which is not the mixed venous saturation. Now, as you mentioned, there are certain things can lead to either increase oxygen content or decrease oxygen content or partial pressure of oxygen within the mixed venous blood. And the more practical way to measure in ICU is using the SVO2, using the PA catheter. And the conditions that lead to high SVO2 are mainly increased oxygen delivery, either because of increased FiO2, hyperoxia, or hyperbaric oxygen. It could be because of the decreased oxygen demands, such as hypothermia, anesthesia, or neuromuscular blockade. And sometimes when there is oxygen extraction is less in a very high flow states, or also called as speed shunts, the conditions like sepsis, hyperthyroidism, or severe liver diseases. The thing where we get low mixed venous oxygen saturations are where particularly there is a decreased oxygen delivery, which is commonly seen in anemia or in case of bleeding or hemodilution. It can be also seen in hypoxic states where there is a decreased oxygen delivery, or it could be because of there's an increased oxygen demand, for example, in cases with hyperthermia, shivering, pain, and seizures. Now, the normal cutoff for mixed venous oxygen saturation is around 65 to 70%. And if you remember the old reverse trial where patients with septic shock, when there is a mixed venous saturation less than 60%, it was recommended to give blood transfusion blindly. Obviously, that's not the practice anymore now, but mixed venous saturation was one of the key component of measurements in patients with shock. Now, what we need to think about is when there is a mixed venous saturation is more than 80%, but then you are seeing the features of hypoxia. And that's where you need to be thinking about where is the problem, and could be because of either microvascular shunting seen in sepsis or in cyanide poisoning. So I think the whole concept of mixed venous oxygen content, partial pressure, and saturation is really important and need to be studied in detail. So thanks, Maddie. So that's kind of our end of today's podcast. Obviously, it's very hard to cover all concepts of respiratory physiology in 2 podcasts. So we will be bringing more episodes on respiratory physiology in the future. But as the new year starts, maybe I was thinking whether are we going to start some new tradition to end our podcast?
No. I think, there's value in old traditions.
Okay. So what's in the store for me for today?
Okay. Why did the monarchy end when the king was asphyxiated?
Maddie, I really can't think of connection between king asphyxia and whole monarchy side of things. But look, if anybody gets asphyxiated, I guess they get hypoxic and then they suffer from hypoxic brain damage.
No, there was no heir to the throne.
Oh my gosh. Here we again start 2021 with my failure of the year. The saga continues. So that was a good joke, Maddie. Well done. I can see you're putting a lot of efforts in creating these jokes.
Yeah, I think it's my favorite part.
Yeah, so a lot of people do agree with you on that thing. So yeah, let's keep our tradition for 2021. So I guess, Maddie, you're taking some time off. So wish you all the best for your exams, and we will bring our primary prepcast episodes once Maddie is done with her exams. So
Yeah.
So wish you all the best, and
Thank you.
we'll be back probably in the month of March or April. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.